Hello, this is Dr. Jason Cuellar. Today we're going to talk about lumbar artificial disc replacement, and in particular, we're going to discuss the selection of the endplates when using a ProDisc lumbar artificial disc. I am an arthroplasty spine surgeon out in South Florida, and this talk is somewhat in conjunction with Sentinel Spine. I'm speaking on my own behalf, but I have borrowed some slides that we developed with their team. So the discussion really centers around what is new and what has changed. The ProDisc has been available for many years, but there are now some more options that have not been available, and this has, I think, caused some confusion to some surgeons. So the original first generation shown on the left here, and the now second generation is currently in use. In Europe, they had all along these modular endplates that we actually have not had here in the US. So all we have originally had for many years was 6-degree or 11-degree total lordosis. When I talk about 6 or 11, I'm talking about total implant lordosis. Okay, and we had three height options: 10, 12, and 14 millimeter. And then we had two footprints: medium and large. Okay. Now, as of a few years ago, we have some more options, which you can see on the right here. Now we can make up that 6 degrees with a 3-degree plate on the bottom and a 3 on the top to total 6, or we can use the original ones where there was 6 on the top and 3 on the bottom. Or we can make an 11-degree implant by obviously adding the 3 and the 8. But the nice thing about the new 11-degree versus the old one was the original 11-degree, the entire 11 degrees of lordosis was built into the upper end plate, which to me never made any sense. So now we can build up the sacrum, and this is the key: build up the sacrum with an 8-degree lower end plate. And the sizes have otherwise stayed the same, right? So FDA has only approved 6 and 11. You can't mix and match and make up any other angles, and you wouldn't want to anyway, right? So we can either do 6 or 11. And like I said, it can be 6 on top, 0 on the bottom, or 3 and 3 to make 6. With the 11-degree, you have the old option of 11 and 0, which I don't think we should ever use. I think we should just throw that away. I don't know why you need that. Or we have the 8 and 3, which I think is going to be your go-to for your patients at L5S1 with a steep sacral slope. And we'll get into that, okay? So I'm going to kind of skip over some of this, but be aware that they've implanted this disc a lot of times without problems overall. But we really needed something different, I think, for some of these patients with steeper sacral slopes. Okay, so here is, I think, the kind of the meat of the discussion is really building up the sacrum. Okay, and previously I would only do patients that had less than a 45-degree sacral slope, and we're measuring sacral slope based on the horizontal of the floor. Okay, so patients with, for example, a 50-degree sacral slope, that's a very steep angle. Previously I wouldn't do those. Now my cutoff is 50. So now with the modular end plates, I'm able to push the indications a little bit more. Okay, so why are we concerned about sacral slope? I think when you're deciding whether to do lumbar arthroplasty, particularly at L5S1, L5S1 is the failure level. Okay, why is it the failure level? Why are we worried about it at L5S1? This little green graph shows us everything. Basically, the force required, and this is biomechanical testing, the force required to cause failure, and we're talking about failure of the core interface with the metal end plate. If you look at the force required to cause failure when there's a 10-degree slope versus a 45-degree slope, you see a big difference there, right? It takes way more force to cause failure with a flat sacral slope. When you get to 45 degrees, it takes less force. So that's why we're concerned. Otherwise, the ProDisc lumbar instrumentation is the same. There's just a slight difference in the end plates, but the trials are the same, right? Okay. Now, here are some case examples, and some of these are going to be Dr. Marnay's and some of these are mine. But you know, I think most important to look at is the sacral slope, right? This patient has a two-level degenerative disc disease, pretty high sacral slope. And if you look at the x-rays, you know, post-op, compare them to pre-op, and I have a case like this a little bit later, you can see when you build up the sacrum with that 8-degree end plate on the bottom, you're horizontalizing the sacrum, right? So you're sort of fixing that problem a little bit of having too much sacral slope or too high of a sacral slope in some of these patients, okay? So how do we choose which end plate to use, right? And this part's Dr. Marnay's. So he's got this algorithm, right, which I mostly use, just taking the 4 parameters into account. So the type of spine, do they have a lot of lordosis, right, or not that much, right? So obviously, we don't want to get too much into this, but there's a this balance corridor where if a patient has a lot of sacral slope, they're going to need more lordosis, they're going to have more thoracic kyphosis, and everything's going to be balanced, hopefully, right? So the type of spine is going to have an effect. Which level we're operating at? Is this going to be up at 2-3 or 3-4, or is this going to be down at L5S1? And then the sacral slope when we're talking about 5-1. So is it a 33-degree sacral slope or is it a 52-degree sacral slope, right? If it's 33, or so generally, and I think he agrees with this, or he came up with this and I agree with it, is 35 degrees or less, you're typically going to use a 3 and 3 to make 6. If you're above 35 degrees, you're typically going to lean towards an 11-degree implant. You're going to trial first, of course, and make sure it fits well, and that's going to be an 8 and a 3. Okay, and then, like it says here at the bottom, after you do the release and the height restoration, which one fits well, obviously. Okay, so here's to kind of summarize this again. Now, Dr. Marnay likes to use a 6 and 0 when it's up at 2-3 or 3-4. So, you know, I think he generally knows what he's talking about. So I wouldn't totally disagree with that. Okay. At the L45, I'm usually always using a 3 and 3. Okay. At the L5S1, as I mentioned, if it's less than 35 degrees, we're going to go with the 3 and 3. If it's more than 35 degrees, we're going to go 8 and 3. Okay. Now, if it's more than 50 degrees, think twice about ADR. In fact, I typically am not going to do an ADR if it's more than 50 degrees. And is there literature evidence of this? No, not really. There are, as far as I know, there are only 2 studies. They're both done out of Cedars-Sinai. One of them showed no difference. One of them showed possibly the 60-degree sacral slope patients did a little bit worse, but very, very small studies. So right now, my current cutoff is 50 degrees. Now, Dr. Lamon and I have a couple of cases here. This is an older case of mine. which I use an 11 degree because the 6 degree did not fit well, and I felt like I needed more lordosis. But you see here, you see this gap beneath the sacral end plate, and the lower end plate, and even with an 11 degree. But now this patient has 11 degree on top, which really makes no sense to me. So, but this was before we had the angled end plates, so I wish I would have had angled end plates for this case. Okay. Now, what about this patient? This is a 66-year-old gentleman with low back pain radiating to posterior calves and ankles. Now, he has at L5S1 a very flat slope, but L5S1 is actually not his biggest problem. 3, 4, and 4, 5 are his major problems. This is illustrating a 2-level case and kind of pushing some indications here. He does have a spondylolisthesis, grade 1, stable. He does have stenosis, okay, at both levels. He does have bony stenosis with some facet arthropathy. This patient really did not want fusion, so we agreed to proceed with 2-level arthroplasty. Okay, we're able to expose both levels at the same time, 3, 4, and 4, 5. Actually did releases, trialed both levels at the same time, and chiseled. You see there on the left, chisel at 4, 5, chisel 3, 4, implant going in 4, 5, 3, 4. So this patient ended up, for this patient, I use a 3 and a 3 at both levels. No reason, in my opinion, you should never use an 11 degree at any level but L5S1. The one case I've seen somebody use an 11 degree at 4, 5 and it failed. It actually caused the polyethylene core to spit out anteriorly. And I had to revise that patient. This is not a fusion. You're not trying to get a hyperlordotic cage in there, right? Never use 11 degree at any level but L5S1. Okay, that's my rule. That's my recommendation. Okay, I did turn this patient over and do a lumbar decompression, direct lumbar decompression, because he had bony stenosis causing lateral recess stenosis. This is the patient post-op. He's now a couple years out, very happy, no leg pain, no back pain. Okay, this is another 2-level case, which I think illustrates nicely the horizontalization of the sacrum with the modular end plate. So this is a younger patient, 44, chronic low back pain. He's a competitive athlete, triathlons, mountain biking, but he really can't do these sports currently because of the back pain. You can see he's got a steep sacral slope. He's got multi-level degenerative disc disease. Right, so 50-degree slope. This is right at my cutoff point. Right, no instability. Okay, MRI shows he's actually got disease at every single level, but his pain was focused lower, and we did do medial branch blocks and other injections to help confirm the localization of the pain, but no pain up above the belt line. CT examination showed normal facets overall. So ended up doing just the bottom 2 levels. Okay, and here's an example of using a 3 and a 3 at 4, 5 for a total of 6, obviously, and 3 and an 8 for a total of 11 on the bottom. Okay, here's intra-op, and here's post-op. Now, if you compare his pre-op X-ray, and I can't explain why it changed so much. Marnay explains that they do tilt their pelvis, when they have back pain, and so maybe that's changing the pelvic tilt a little bit. But if you look at his sacral slope before versus after, it actually has horizontalized a little bit, even if you measure the bone. But if you look at this picture all the way to the right, if you measure the end plate of the implant, see we've horizontalized the sacrum even more, right? And then look at what's going on up at 3, 4. So you look, we've actually corrected some of his hyperlordosis there, because when he has, in essence, pre-op a flat back syndrome because of relative kyphosis at L4, 5 and L5S1. Now he's compensating for that with the hyperlordosis at L3-4, relatively speaking. If you look at post-op, he's flattened out that level, right? So I think that's an interesting case. So that's the end of the discussion. Feel free to email me with any questions at cuellarj@gmail.com. Thanks very much.